You walk into room 4. Your patient, a 65-year-old woman, is leaning back against the pillows, and she says she's just, incredibly tired.
Yeah, a super common complaint.
Right. And she rubs the center of her chest, mutters something about having terrible heartburn from the hospital lunch.
Uh-huh.
She's a little pale, maybe a bit sweaty, but she's awake and she's talking to you. It would be so incredibly easy to just grab an antacid, dim the lights, and tell her to get some rest.
Oh, absolutely. But inside her chest, right at that very second, her heart muscle is literally suffocating.
Exactly. She's in the middle of a massive life-threatening heart attack, and her window for survival is closing by the minute.
So how do you tell the difference between mundane indigestion and a lethal cardiac event before the damage is irreversible?
That is the ultimate test of clinical judgment, and it's exactly what we're getting into today. Welcome to the Super Nurse Podcast.
Yes, welcome.
Now, this show was created by Brooke Wallace. She's a 20-year ICU nurse, organ transplant coordinator, clinical instructor, and published author.
She really has seen it all.
She really has. And just to be clear, we're not Brooke. We're your hosts, but this entire episode is built directly from her bedside knowledge, her notes, and her teaching style.
Right. Our goal is to help you, the nursing students and the new nurses out there, apply what you learn in school to real patient care.
Exactly. So before we jump in, make sure you subscribe and watch the video on YouTube. The link is in the description. And our channel is called Super Nurse AI.
You'll definitely want to follow along.
For sure. So today we are tackling the clinical management of acute myocardial infarction, or MI, and we're going to break down the mechanics so you can recognize the subtle clues at the bedside.
Because emergencies rarely map perfectly to the textbook diagrams, right? The presentation is messy. The symptoms can be really subtle.
Yeah, so let's start with the physiology. Before we can treat the patient, we have to understand the physical crisis unfolding inside the coronary arteries.
Well, what we know from practice is that it typically starts with atherosclerosis.
Right, the long-term buildup of cholesterol and plaque on the vessel walls.
Yeah, but the acute emergency, the actual MI, is triggered by a sudden rupture. The transition from a chronic condition to an acute crisis is violently fast.
Like, how fast are we talking?
Minutes. A patient might live with stable plaque for decades without severe limitation, but when that plaque suddenly fissures or breaks open...
The body goes into panic mode.
Exactly. The body perceives that rupture as an injury that needs to be patched, which triggers a massive inflammatory and coagulation response.
Right.
Platelets rush to the site, they aggregate, and boom, they form a thrombus, a blood clot.
And that clot partially or completely occludes the artery.
Right.
It's essentially like a house's plumbing system.
Hmm.
For years, there's been this slow, insidious buildup of grime inside the main water pipe.
Huh?
The water is still flowing, but then a sudden structural failure causes a massive hairball, which is the ruptured plaque combined with the new blood clot, to just wedge itself in the narrowest part of the pipe.
I love that analogy. And once that hairball blocks the pipe, the flow stops completely.
The bathroom, representing the downstream heart muscle, instantly loses its entire supply.
And that's when the clock starts on coagulation necrosis. Heart muscle cells have an incredibly high metabolic demand. Without oxygen, the cellular machinery just fails.
They literally die.
They do.
Yeah.
And they do not regenerate. Once they die, they're replaced by non-functioning scar tissue, which permanently compromises the heart's ability to pump.
Which means your primary goal at the bedside, while you're coordinating the effort to unblock that pipe, is to drastically reduce the heart's workload.
Because if the heart is beating faster or pumping harder, it demands more oxygen.
Right, and when that demand meets a blocked supply, the cell death spreads faster. So how do we translate that microscopic cellular crisis into the physical symptoms sitting right in front of us?
Well, the classic presentation involves Levine's sign. That's where the patient instinctively clutches the center of their chest.
Ah, the classic chest grab.
Yes. They describe a crushing, heavy pressure. You'll hear them say it feels like an elephant is sitting on their chest. The pain is usually substernal and radiates down the left arm, up into the jaw, or through to the mid-back.
And alongside the pain, the body's systemic alarm bells are ringing. We see severe diaphoresis.
Right, the sweating.
Yeah, the sympathetic nervous system dumps adrenaline into the bloodstream in a complete panic over the failing cardiac output. The skin gets cold, clammy, and dusky.
Because blood is being shunted away from the periphery to protect the vital organs. Shortness of breath and sudden nausea are also super common here.
So when we see this, we utilize the PQRST assessment framework, right?
Yes, PQRST is the standard. But understanding why we ask each question is what elevates your assessment. P is for provoke. Did exertion trigger this, or did it happen at rest?
Because pain at rest suggests a highly unstable plaque.
Exactly. Then Q is quality. Is it sharp and stabbing, which might be a pulmonary issue, or is it that dull, crushing pressure?
Got it. And R is radiation, tracking those nerve pathways to the arm or jaw.
Right. S is severity, establishing a baseline so we know if our interventions actually work. And finally, T is time.
And time might be the most critical variable of all, right?
Absolutely. Knowing exactly when the pain started dictates the entire treatment algorithm. Are they still within the window for clot-busting drugs or urgent catheterization?
But there's a massive bedside trap here, isn't there? Because the textbook PQRST works beautifully for the classic presentation, but many patients don't look like that.
Oh, for sure. We see atypical symptoms all the time, what we call silent MIs. Women, the elderly, and specifically patients with diabetes frequently bypass that classic chest clutching entirely.
Wait, really? Why is the diabetic population so vulnerable to this?
It's due to diabetic neuropathy. Years of elevated blood glucose levels cause systemic damage to the peripheral and autonomic nerves.
So the nerves are essentially numbed.
Exactly. Because those sensory nerves are blunted, the brain literally does not receive the severe pain signals from the starving heart muscle. The necrosis is happening, but the alarm system is disconnected.
Wow, so instead of crushing pain, what do they feel?
They experience profound, generalized fatigue, shortness of breath, or vague epigastric discomfort.
That basically just mimics indigestion.
Right.
But if a diabetic patient just complains of mild heartburn and feeling tired, sounding the alarm for a rapid response feels like a massive escalation.
Yeah, it does.
I mean, there's a real fear of crying wolf at the bedside, you know? Triggering all these protocols for a patient who just needs a GI cocktail, that feels like a quick path to alarm fatigue for the whole nursing unit.
I totally get that. The fear of alarm fatigue is a valid concern for newer nurses. But clinical experience shows us we have to shift our risk assessment here.
How so?
An unexplained, sudden onset of fatigue or epigastric discomfort in a diabetic patient must be treated as a cardiac event until definitively proven otherwise.
So assume the worst first.
Always. The consequence of overreacting is just a temporary disruption and a quick negative workup. The consequence of underreacting to a silent MI is irreversible heart failure or death.
That makes total sense. And it's also worth noting that clinical research shows Black patients have a significantly higher incidence of MI, which requires heightened clinical vigilance, especially with these atypical presentations.
Yes. Demographic awareness is a huge part of your clinical judgment.
So suspicion gets the ball rolling, but you need objective data immediately. You need to prove the pipe is blocked.
And the fastest, most accessible way to get the heart's electrical footprint is the 12-lead ECG. Guidelines mandate you get that within 10 minutes of a patient reporting acute chest pain.
10 minutes? That is fast.
It's an absolute metric for bedside care. The ECG acts as the sixth vital sign because the electrical conduction system of the heart is highly sensitive to hypoxia.
So the electrical signals change before the chemical markers even show up in the blood.
Exactly. When the cells are starving, their ability to conduct impulses changes instantly.
I like to think of the 12-lead ECG as a 12-camera security system placed around the exterior of a building. Each lead gives you a specific viewing angle.
That's a great way to visualize it.
If one camera shows suspicious activity, like a break-in on the lateral wall, you never just rely on one angle. You look at the contiguous lead, the camera right next to it, to confirm the damage.
And when we analyze those camera feeds, we're differentiating between two categories of MI, the STEMI and the InSTEMI.
Let's break those down.
Sure. STEMI stands for ST elevation myocardial infarction. This is the catastrophic, complete occlusion of the artery. Full-thickness muscle death is happening. On the monitor, you're looking for an elevation of the ST segment at the J point.
So the functional rule for the bedside is ST high means the heart muscle is dying.
Yes, ST high means dying. Now, an NSTEMI, or non-ST elevation myocardial infarction, usually points to a severe partial blockage. Blood flow is restricted, causing profound ischemia, but it's not a total occlusion.
And the electrical signature looks different.
Right. You'll see ST segment depression or T-wave inversion instead of elevation.
So the rule there is ST low means low oxygen.
Exactly. ST high for dying, ST low for low oxygen. It's a really effective cognitive shortcut when you're in a crisis.
But the ECG is still an indirect measure, right? To confirm the diagnosis beyond a shadow of a doubt, we need the chemical proof. We need blood labs.
Yes, we are looking specifically at the cardiac biomarkers, troponin I and troponin T. These are proteins that belong securely inside the heart muscle cells. They help the tissue actually pump.
They have absolutely no business being in the general bloodstream.
None at all. But when that coronary occlusion starves the tissue, the cells die and rupture. As they burst, their internal contents, including the troponin, spill out and wash into the systemic circulation.
So detecting elevated troponin in a venous blood draw is the definitive chemical signature of cardiac necrosis.
Right. Normal levels are virtually undetectable, usually between 0 and 0.4. The moment that value crosses 0.4 or 0.5, we have chemical confirmation of cardiac injury.
But wait, this raises a really interesting practical question. If troponin is the absolute gold standard for proving a heart attack, why the intense protocol-driven rush to get an ECG in 10 minutes?
Oh, that's something newer nurses ask all the time.
Like, why not just draw the blood, send it to the lab, and make the decision based on the chemical proof?
Because waiting for the lab relies on a process that is just too slow. We operate on the principle that time is muscle. Troponin levels do not even begin to rise above baseline until 4 to 6 hours after the ischemic event starts.
Oh, wow. So if a patient hits their call light 30 minutes after the chest pressure starts, their initial troponin draw is going to come back perfectly normal.
Exactly. Even though their heart muscle is actively dying right then and there,
Yeah.
relying on that single early lab value will give you a false sense of security.
So the ECG reflects the distress instantaneously, but the blood takes hours.
Right. We act on the electrical changes immediately to save the tissue, rather than waiting hours for the chemical autopsy to confirm the tissue is already dead.
That makes so much sense. And that delayed release is also why we perform serial troponin testing, right? Drawing blood every few hours to monitor the trend.
Yes. We need to see if the levels are rising, peaking, which usually happens around 18 to 24 hours, or if they're finally plateauing.
So you've recognized the subtle symptoms, you've got the ECG in under 10 minutes, you've identified the ST changes, and sent the blood for serial tracking. Now comes the intervention.
And this is where things have really evolved. The traditional mnemonic for the NCLEX is MONA, morphine, oxygen, nitroglycerin, and aspirin. But modern evidence-based practice has significantly updated how we actually use these at the bedside.
Right. MONA is not just a linear step-by-step checklist. Let's look at oxygen first. Historically, high-flow oxygen was universally slapped on anyone with chest pain, right?
Yes, under the assumption that more oxygen is always better for ischemic tissue. But current evidence strongly refutes that.
Wait, really? Too much oxygen is bad?
Yes. Hyperoxia actually causes coronary vasoconstriction. It narrows the pipes further and increases damaging reactive oxygen species. So now, we only administer supplemental oxygen if the patient's saturation drops below 90%.
Wow, okay. Then there's aspirin. We aren't giving it for pain relief, obviously.
Right, we give a full 325 milligram dose and instruct the patient to chew it for rapid absorption.
Because chewing it gets it into the system faster. And returning to our plumbing analogy, the aspirin acts on the platelets. It makes them slippery.
Exactly. It fundamentally inhibits their ability to aggregate. Now, it won't dissolve the hairball that's already blocking the pipe.
But it stops new platelets from piling on and making the clot bigger.
Right. Following the antiplatelet therapy, we need to address the physical diameter of the pipe itself, and we do that with nitroglycerin.
Administered sublingually. Nitro is a potent systemic vasodilator.
Yes, it forces the smooth muscle in the vascular walls to relax. It widens the coronary arteries to allow some blood flow to bypass the obstruction.
It also dilates the peripheral veins, right, which reduces the volume of blood returning to the heart.
Yes, it effectively lowers the preload and decreases the heart's overall workload.
But before you hand a patient that nitro, there is a massive, non-negotiable bedside safety check. You must ask the patient if they've recently taken sildenafil, commonly known as Viagra, or any other drug for erectile dysfunction.
Or pulmonary hypertension, yes. Both of those medications are profound vasodilators. If they are active in the system at the same time as nitro, the synergistic effect causes a catastrophic, irreversible drop in blood pressure.
It leads to fatal vascular collapse.
Absolutely fatal.
Yeah.
And even without Viagra in the system, nitroglycerin is going to cause a rapid decrease in blood pressure.
The patient is probably going to get a sudden severe headache and become incredibly dizzy.
Oh, yeah. So as a practical measure, the patient absolutely must be sitting or lying flat in the bed before you give it to them to prevent them from passing out and falling.
Okay, so the final letter in MONA is morphine. But its role has been heavily downgraded recently, hasn't it?
Very much so. We no longer use it as a primary first-line intervention. It's generally reserved for patients whose severe pain just isn't responding to the nitroglycerin.
Because while morphine does reduce anxiety and lower the heart's oxygen demand, it can also mask worsening ischemic symptoms, right?
Yes, and it can potentially interfere with the absorption of other critical antiplatelet medications. So when you look at a crashing patient, your priority is driven by the mechanism of action. Aspirin halts the clot. Nitro tries to restore the flow.
But it's vital to remember that MONA is palliative in the short term. These medications just buy you time. They do not cure the underlying mechanical obstruction.
No, they don't. The ultimate fix requires a physical intervention. For a STEMI patient, the gold standard is activating the cath lab for a PCI, a percutaneous coronary intervention.
And the clinical benchmark there is a door-to-balloon time of 90 minutes.
Right. A cardiologist threads a catheter into the coronary artery, physically inflates a balloon to crush the plaque, and deploys a wire mesh stent to hold the pipe open.
And if the blockages are too complex, the patient moves to a CAPE-G, a bypass graft surgery, where they physically construct new plumbing roads.
Exactly. Bedside management of an MI is entirely about stabilization and rapid triage. You're managing the systemic fallout of a cellular crisis, balancing oxygen supply and demand, and securing the window of opportunity for the surgical team.
Okay, so let's summarize the really important bedside flow we've covered today. It all hinges on high clinical suspicion, especially recognizing those atypical presentations like profound fatigue in diabetic or female patients.
You grab the 12-lead ECG within 10 minutes to capture the electrical distress. You look for ST elevations indicating a total blockage, or ST depressions indicating subendocardial ischemia.
You draw the serial labs to track the troponin leak over the next 4 to 6 hours, and you systematically deploy targeted pharmacology aspirin to halt the clot, nitroglycerin to dilate the vessels, while constantly monitoring hemodynamics.
The pathophysiology can definitely feel intimidating at first, but when you connect the cellular mechanisms directly to the physical symptoms you see at the bedside, the clinical decisions actually become highly intuitive.
You aren't just memorizing an acronym, you are manipulating the variables of supply and demand to keep human tissue alive.
You're learning how to think, not just what to memorize.
Exactly. Now, as we wrap up, I want to leave you with a really fascinating, provocative thought based on emerging clinical evidence.
Whoa, this is a good one.
We operate on the rule that troponin only enters the bloodstream when a heart cell undergoes irreversible necrosis and bursts.
Right, that's the standard assumption.
Yet sports cardiology data shows that perfectly healthy, asymptomatic people frequently display elevated troponin levels immediately after completing extreme endurance events, like running an ultramarathon.
It's wild.
Well,
It completely forces us to question the absolute rigidity of the cellular rules we just talked about.
like, does pushing the human body to the absolute edge of its limit induce microscopic transient heart attacks in healthy tissue? Or is there some completely separate, mysterious mechanism where an intact living heart cell can temporarily sweat or leak this massive protein under extreme mechanical stress without actually dying?
The cardiology community is still debating it. It's a brilliant reminder that while our clinical guidelines are incredibly precise, the human body still holds mysteries that defy the textbook.
It really does. Definitely something to think about the next time you're staring at a baffling lab result at the bedside.
Absolutely.
All right, that is it for today. Thank you so much for joining us on this episode of the Super Nurse Podcast. Make sure to watch the video on YouTube, like, subscribe, leave a comment, and visit supernurse.ai for great resources helping you become the super nurse you were born to be. Catch you next time.